Good morning or afternoon, wherever you are in the world. Thank you so much for this invitation to present. I will be presenting today on understanding the strengths and vulnerabilities of those most impacted by HIV and what implications that has for vaccines development and vaccine campaigns. As you all probably know, the state of HIV vaccine research is very exciting right now. Particularly earlier this year, we learned through HVTN 703 and 704 that the antibody VRCO1 neutralizes some strands of the HIV virus. And excuse me. And currently, HVTN 705 and 706 are examining the efficacy and safety of a mosaic-based vaccine regimen for both cisgender women and men and transgender people who have sex with men and or transgender people. Um, and we hope that those trials um, reveal new and exciting findings and kind of push us along on this journey of discovering a vaccine for HIV. And so I want to talk about and really center my talk today on how we engage and lift up those most impacted by HIV to ensure that they are actively engaged in vaccine development and also prioritized, engaged when we have a vaccine for distribution. And so you can see this is some of the most recent research on those key populations most impacted by HIV globally. And we see that a large majority of those impacted are clients of women who engage in sex work, as well as other partners of key populations, followed by gay, bisexual, or otherwise men who have sex with men, and then people who inject drugs. But then we also see a large percentage of people who are impacted by HIV as the remaining population. So I want to kind of focus a little bit on the remaining population and what that might look like from an intersectional perspective. And as I do that, I really want to center the people who are most impacted by HIV, which, if we look at globally from an intersectional perspective, are people of color, and even more specifically, people of African descent. So we know that in the United States, African American women and men who have sex with men or gay or bisexual men are among the highest priority population because they account for the majority of new HIV cases in the United States. And then if we move to other parts of the world, like sub-Saharan Africa, we know that young women and adolescent girls are at enormous risk for HIV acquisition. And we know that also transgender women, particularly Black trans women, are disproportionately impacted by HIV. And so when I talk about using an intersectional approach, I'm talking about understanding those most impacted by HIV based on kind of a confluence of identities that have been historically underserved, underappreciated, and marginalized. So, for example, we know that globally, 50% of women and girls, that globally women and girls account for about 50% of all new HIV infections. But we know that those new HIV infections are not equally distributed across all women and girls. For example, African American women and young adolescent girls and young women in South Africa are disproportionately impacted, and those are Black adolescent girls and young women and African American women in the United States. We also know that in general, the rate of African Americans is 9 times higher than the rate of whites in the US, and that the prevalence of HIV among Black South Africans is much higher than the prevalence compared to whites. And so when we look at some of these statistics and we understand the intersection of one's gender or gender identity and their race, I think it paints a very clear picture that it's very important to center and prioritize Black people across the globe as we start to develop vaccines and get ready, hopefully, for the distribution of a vaccine in the future. And so oftentimes we talk about underserved populations, we talk about the risk or the vulnerabilities related to those populations. And those risks and vulnerabilities are valid and important, but I also think it's important to think about the resiliency of populations that have been historically underserved. For example, we know that adolescent girls and young women are responsive to gender focused interventions when they are appropriately tailored and developed. And an example of this is the Dreams Initiative that's happening and recently, there were some promising the results that came out of Zimbabwe. Our research team at RTI has been doing this work led by Dr. Wendy Wexberg, for several years. And we have seen promising results when we tailor and center the voices and the experiences of women in HIV prevention interventions. We also know that resiliency mitigates the effects of minority stress on gay Black men or other men who have sex with men in a way that resiliency really mitigates the effects of minority stress on HIV risk. And we also know that gender affirmation is an important source of resiliency that can positively impact the sexual risk behaviors or the ways in which trans people navigate their sexual behaviors in order to protect themselves from HIV. But of course, there are some very real vulnerabilities that people experience, especially those who are most impacted by HIV. For example, we know that Black people across the globe are disproportionately affected by poverty because of colonization and um, lots of other historical experiences that have occurred. And poverty has tempered most recent HIV treatment and prevention advances, so much so that some authors have coined HIV the pandemic of the poor. We also know that substance use plays a role in how people access and adhere to treatment and are retained in care, and that stigma and discrimination is a significant barrier, especially among those with multiple marginalized identities, and can really impact the reach of biomedical HIV prevention methods such as PrEP and in the future, a vaccine. Lastly, gender inequities intersect with other social determinants of health to really impair women's ability to take advantage of medical advances. And we saw this very clearly in the Voices trial, where when researchers really dug deep into why women were not adhering to PrEP, a lot of the reasons that were offered up were related to disclosure and partner dynamics. And so now I'll take us a little bit kind of through some lessons learned from both vaccine trials as well as PrEP developments and most recently COVID-19, and how all three of these experiences, medical advances, really offer up some really key lessons learned for how we can go forward and be better as scientists, centering the voices of Black people who are most affected by HIV as we develop vaccines and vaccine campaigns. So two very important lessons I think that we've learned as a field so far from vaccine trials is that stigma is a consistent barrier to participation in trials and probably will be a very significant barrier to the uptake of a vaccine when it is available. And then there really is a need to acknowledge and rectify and rectify the harm that has been caused by people to people of color by scientists. And this article is a bit old, but I think is a really illustrative example of how scientists um, can be more thoughtful about how we engage in trials and what implications that thoughtfulness might have for the receptivity of vaccines when they are available, especially among Black people across the globe. So in this paper, researchers really um, delve into understanding the perspectives of participants who engaged in HIV vaccine trials and the aftermath of an early termination of the trial. And I think this quote is really highlights kind of how people might feel when the trials end or end prematurely. And we do not communicate, as scientists, do not communicate as thoughtfully as we might could have. And so this idea of being once bitten, twice shy. So kind of fool me once, shame on me, fool me twice. So fool me once, shame on you, fool me twice, shame on me kind of thought process. And so when we are starting trials, when we are ending trials, I think it is just very important that we be overly responsive to the past experiences of communities when it comes to medical developments and the future hopes that we hope to offer these communities. And we want them to be in a place where they are able to receive the developments as they become available. And now I want to think a little bit about some of the lessons that we've learned from PrEP research. And so our team at RTI is doing some work, and I know probably many of you on the webinar are also engaged in this work. And I think what we have seen and the research bears is that people are very enthusiastic about PrEP and HIV prevention in general, including vaccines. But we really have to take their concerns and the barriers seriously. And when we don't, we see that even with the best medical advances, our goal of ending the epidemic will not be achieved. We should also give people the ability to choose their preferred method of HIV prevention. And I think that's very important because, as I'll show on the next slide, everyone may not want a vaccine or everyone may not want a pill. And so it's very important that we work as quickly as possible to provide as many modalities of HIV prevention as possible. And then again, this idea of stigma that will continue to be a significant barrier to uptake unless we proactively address it. So proactively train our providers to be more in tune to the concerns of our most prioritized populations. And so this is just some research that highlights how different populations may uh, prefer to engage in HIV prevention. And as you can see from this slide, um, depending on the population, the preferred method varies widely and greatly. And so it really is up to us to take these preferences seriously and work as hard as we can to provide people with these options, including through the supply chain. So not just the development of these modalities, but the actual ability for people to go into their free clinic and take advantage of these advances. And so our team at RTI has done some research. I just wanted to end on a hopeful note that we really are moving in the right direction. So in 2017, our team conducted two kind of simultaneous trials. One is in was in North Carolina in the United States among young African-American women who reported substance use. The other was in Cape Town, South Africa, among adolescent girls and young women who also engaged in substance use and had discontinued school early. And what we see is in 2017, about 31 to 32% of both African American young women and South African young women reported hearing about PrEP. We have an ongoing trial now that is engaging health clinics to both reduce stigma and increase uptake of PrEP, birth control, and condom use among adolescent girls and young women. And what we see is that we've gone from about 30% being aware of PrEP to now 62 of the young women in the study being aware. And so this is encouraging news. We're moving in the right direction. We just have to continue to consider the voices of our populations in our research. And then if there's one uh, lesson I think we have learned in terms of engaging Black people across the globe during COVID-19, it's been we have to understand structural racism as the main barrier to vaccine uptake among Black people. So this is just a brief snapshot of some of the most recent research in the United States about vaccine uptake. And as you see, among those who have received at least one dose of the COVID-19 vaccine, 9% are African American, although African Americans make up 12% of the US population. And so there is a disparity. And this disparity has often been attributed to vaccine hesitancy among Black people, both in the United States and in other parts of the world. But I think Dr. Giselle Corby-Smith has written a very compelling commentary in JAMA about how vaccine hesitancy can be used as an excuse or a scapegoat for structural racism. And really, a better way to think about the disparities of vaccine uptake among Black people may be to really understand structural racism and how structural racism has impacted both African Americans' willingness to engage with the vaccine, as well as their access points for the vaccine. For example, we know that historically African Americans in the United States and Black people in other parts of the world have been exploited for the medical advancement for other populations. And so it may be more helpful to think about their vaccine, their hesitancy to engage with the vaccine as honoring and understanding their decision to be very deliberate about if and when they take the vaccine, given the historical context of medical developments among Black people globally. It's also really important to use an equity lens when we think about vaccine uptake and why more people of color are not engaging with the COVID-19 vaccine. And this has direct implications for the HIV vaccine. So when we think about how, for example, people can make appointments, if the vaccine is available in certain areas, and who are the people who are promoting the vaccine? Are they trusted partners? All of these are really important questions to answer. And I think if we take one lesson from the webinar, I think this would be it, is that we really have to take the onus off of those who have been most marginalized, are most impacted by HIV or other diseases like COVID-19, and really take the responsibility ourselves to understand how structural racism may be playing a part or is playing a part in the vaccine development process, as well as the dissemination and uptake decisions of people who we hope to serve. And so I think the three main ideas that I like to offer up for today about how we can be better in terms of development of vaccines and dissemination and development of campaigns is that we really, as scientists, have to acknowledge the history of Black people across the globe and communicate our efforts to redress the past experiences. And the development of vaccines as well as the dissemination of a future vaccine. And we also have to ensure that the process of developing and dissemination is inclusive and that all people, especially those that we want to prioritize, are at the table. And then ensuring that everyone has equitable access to vaccines, including strengthening the supply chain to ensure that there's no shortage or stock out of a vaccine when it becomes available. And then I'd just like to leave you with this. When we are developing the HIV vaccines, and as we disseminate a future vaccine, which I know we will eventually develop, we really have to ask ourselves two questions, especially as it relates to Black people across the globe who are most impacted by HIV. And that is, are key populations at the table? And are we, as scientists, as decision makers, as policy makers, listening to their voices and prioritizing their voices? I think until we continue to ask ourselves these two questions, any advancement that we, um, you know, are successful in developing will be tempered. The efficacy will be tempered by some of the structural vulnerabilities that these populations experience. But I think as long as we elevate these two questions, we are within reach of ending the HIV epidemic, especially as we develop a vaccine. Thank you.